welcome to AHAtv, supported by Novo Nordisk. I'm Allison Godlove. Joining me now is Dr. Amit Khera and Dr. Joanna Chikwe. Welcome. It's good to see you both again.
Thank you.
It's good to be back in Chicago too. How are you feeling day one?
Really excited. I mean, 5 New England Journal of Medicine late breakers. I mean, that's a great start to any meeting.
Yeah, that is a great way to start this off. So let's talk about some of the clinical trials from today.
Yes, and you know, Dr. Chikwe and I, we had a great time to moderate late breaker 1. So let's dig in. I mean, that's where it all started. I guess I'll start and talk a little bit about this BP Road study because that really kicked off the meeting. I mean, you know, we remind ourselves that hypertension is still the #1 contributor to cardiovascular death in the world, and you know, we were hearing today about how many, you know, millions of people around the world are affected, well, billions actually, by hypertension. So this was not insignificant, right? So this idea of, you know, what should the blood pressure targets be in patients with diabetes, and we know they have so much cardiovascular issues, and the study, 12,000 individuals out of China, half with intensive blood pressure, less than 140, the other half even more, less than 120. Very similar to what was in the ACCORD trial. And what they showed that there was a significant reduction in cardiovascular events and, you know, modest increased risk in some side effects, hypotension, hyperkalemia. But really, it just sort of told us, you know, this is what we need to be doing in patients with diabetes. And it's not, if you think about what that means worldwide, one of the presenters, 800 million people worldwide with diabetes, or, you know, that is a lot. And so this is a really big trial. Now, I have to ask you, because this segues, right? Diabetes, obesity, but the Summit trial we heard about today.
Well, Summit's a great trial. I mean, there you're looking at patients with obesity, right, and HEPAF. So 700 patients, I think, randomized to tirzepatide versus placebo, followed for 104 weeks. And as we've seen with the rest of this drug class, excellent weight reduction, but the real take home is the reduction in cardiovascular events. So I think 14% in the treatment group versus 8% representing with heart failure during that follow-up. So a really significant reduction in adverse cardiovascular events, and trying to sort of move the needle on heart failure, this patient cohort, really, I think, transformational.
Yeah, and it was standing room only for that downstairs, this deep dive. People are really interested in that study.
So which was the next trial that really caught your eye?
Well, let's keep going with late breaker 1, right? So the one with the amyloid. You know, the theme was from prevention to treatment to cure. And so we had the prevention with the blood pressure, the treatment tirzepatide, and this is as close as we get. This was CRISPR-Cas9 editing of transthyretin amyloid in patients with amyloid cardiomyopathy. It's a phase 1 study, but their prior New England Journal article only had 6 individuals. This has 36, so pretty good number of individuals. And as they showed, pretty impressively, about an 80+% reduction in transthyretin amyloid, very few side effects, and generally stabilization in people's disease. So this could be life-changing. It's not quite cured, but we're getting close for sort of a curative one-and-done treatment for amyloid. So really, really exciting stuff in our first session. But hey, we had the second session as well, so let's not forget, and more to come. Second one was all electrophysiology, and packed room again for that. What caught your eye in the electrophysiology one?
Well, I think continuing this theme of risk reduction in patients that present with heart failure, we've got a prevention of VT, right? So VANISH, which randomized 700 patients to ventricular ablation versus, I think, just standard arrhythmic therapy. And again, showing pretty significant reductions from about 60% without ablation to down to about 50% representing with the composite endpoint of VT storm shocks or representation with symptoms. So again, an intervention here that seems to be improving the outcomes of patients in that heart failure bucket, in this case is VTs.
Yeah, quite important. We have one as a drug therapeutic and the other a procedural therapeutic, but both helping patients in that entity. There was another one I guess I would love to talk about, also in the New England Journal of Medicine, that was OPTION. This one, you know, was getting some play even before it came out, just wondering what it might show, but, you know, patients with atrial fibrillation undergoing ablation, pretty common procedure, and then, you know, what to do with anticoagulation, and half of them continued anticoagulation, the other half getting a left atrial appendage occluder device, showing that, you know, from a safety perspective, a lot more bleeding as expected with the anticoagulation. From an efficacy perspective, non-inferior. So potentially could be a differential way that we think about treating patients with AFib. There are some caveats. There were some procedurally related complications. We all know non-inferiority trials can be a little bit tricky, but I think this one will continue to get discussed about maybe a different way we think about patients with AFib. So pretty cool.
I think really cool. And as a surgeon, I think the trials that are really going to get me excited are being presented tomorrow. So I'm curious, as a non-surgeon, which are the trials that you're taking back to work next week that might influence your
practice?
practice?
I mean, there's no question. I think first, the blood pressure one's a no-brainer, right? Our guidelines have 130/80, and now it reinforced that, yes, if there was any uncertainty, this reinforced it. But tirzepatide and HFpEF, we all deal with that, and I think tomorrow morning this changes things, because it's not just about obesity anymore, but actually improving outcomes, heart failure hospitalizations, and it was pretty significant, a 35% or so reduction. So there's no way to ignore that finding. The challenge, of course, these are hard drugs to get and pretty expensive. So
it's not about just taking these trials back to work, it's also taking them home. My husband, I'm going to nag him, 140 is not where he needs to be. We should be pushing for 130, 120.
Your husband's getting something out of this meeting as well, which is great.
So many exciting things today,
right.
Personally, professionally, and that's going to continue as we continue on. So thank you both for joining us for the recap for today, and we look forward to it again tomorrow here at Scientific Sessions. Thank you.
Thank you.
Thank you.
And thank you all so much for joining us.